I asked you to read out a few lines from the books, 3-4 of you. Most read these words palpation, at least 3 of you read this word palpation as palpitation, percussion as percussion, and even one read it auscultation as auscultation or something like that. If you don't know after 3 months how to pronounce these words, then it is better not to remain in this course. Take it as an advice, take it as a warning, anything. Performance is very bad in the exam on an average. I am not speaking of all students, again I am speaking unfortunately of most students. Very, very bad. We tried to make the exam, at least from our department, we tried to make the exam as simple as possible, because many have joined late, which does not occur in other years. In the other sessions, this does not go on. That admission process is going on 3 months after the course has started. So thinking of all of the students together, we made the exam as simple as possible. We omitted this OSPI part, etc. And theoretical questions won't be as straightforward as you got the long question. Name only 6 globin chains. Name 6. You have to know that there are 6. So it appears that almost nobody knows that there are 6 globin chains. They are writing about 2. So that is another part. Okay, we'll start today's topic, today's examination of the respiratory system. If you can't pronounce these words still, with only 6 months left for the exam, then the situation is very wary. Because we discussed at the beginning of starting when clinical physiology, yes, history taking and general physical examination, criteria for general physical examination, criteria for physically examining an individual who has come for medical advice, and 2 topics were discussed separately: examination of the arterial pulse and recording of blood pressure at rest and in grades of different grades of exercise and posture. So we are not going outside the syllabus, but within the syllabus also many things are remaining untouched from the student's perspective. It is no use completing it in the classes, and if you don't practice clinical examination, you will never be fluent with it. Fluent means you cannot perform. Without performing and practicing, students can't perform, not especially beginners. In the medical field, there is a term called practice, doctor's practice. This practice, I think this term has came from there. If someone is not involved in this medical involvement in his medical career for say 2 years, then he or she may lose confidence and forget many things, if not most. So you have to practice, and you are not even being able to pronounce these words correctly. Palpation word, it is not palpitation. What is palpitation? Fast heart rate. Palpitation. It is completely different from palpation. Yes, what is palpation? Palpation means to feel. Palpation, it is to feel the subject by the touch of the clinician. Feel of the subject by the touch of the clinician. What is percussion? We will see during examination of the respiratory system. We have not seen palpation, inspection, palpation and auscultation. We have already discussed in some way or the other, because we studied about blood pressure. We know how to record blood pressure by now. So auscultation means clinical examination with the help of the stethoscope, hearing sounds with the help of the stethoscope. So stethoscope we have used. Inspection, palpation, auscultation we already know. Percussion we have not done till now, but at least you should pronounce correctly. It's not percussion. So as we told in the beginning of clinical examination, most clinical examinations will be done under this. Many, if not most, many clinical examination will be done under these 4 headings: inspection, palpation, percussion, auscultation. Again, for the sake of learning. Same thing as we told in general physical examination, that For the sake of learning, especially for the beginners, we divide it into some headings like what are the points to note in general physical examination? You. Yes, you. In general physical examination, what are the points to note? Okay. And tell the full thing. BP means, what is BP? Blood pressure, yes, and SpO2, okay. What do you mean by clinical examination? Did you attend the exam? Both theory and practical? What do you mean by clinical examination? First say what do you mean by clinical examination or physical examination. So it appears as if you should begin from again, start from the beginning. Maybe next year. If you don't know what is clinical, when did you join? November. So it's already 3 months. So nobody will see when was your internal assessment is just for recording of marks. You have been into the 3 months into the course and you don't know what is, you can't explain what is clinical examination. You are telling SpO2. SpO2 is measured with the help of an instrument. You have heard pulse and SpO2 together, maybe as all people, that means those who are not in the medical profession, even laymen can say pulse and SpO2, that is heard together during COVID times. Respiratory rate, blood pressure, and what did you tell? Pulse. Okay, anything else? To note in general physical examination, not the others. Okay, you? Some other points to note in general physical examination? What are the vital signs? Heart rate or pulse rate, blood pressure, temperature, respiratory rate, vital signs. And are there any other vital signs? We call these 4 as vital signs, right? Will you say later on? Any problem? So what are the so these are the vital signs. So what are the other points in general physical examination? These include these are included in general physical examination, and others. History taking is history taking. It is not a part of physical examination proper. History taking is obviously a part of this management of the medical condition. It includes history taking, management of the medical condition of any individual who has come to us for medical advice. But what are the points to note in physical examination when we are examining him or her physically? You?
Pupil dilation, missing the pupil, then respiratory rate.
Dilatation of pupil. Have you got this in any book? If you have got, it's okay. And that has been already mentioned. Something to do with the color of the skin and etc. What are the points?
By seeing the hand or arm.
Yes. What are the points to note?
That it is red or yellowish or whitish in color.
So what is that called? If it is whitish means the term is not whitish, the term is pale. So what is that called? Paleness, what is called? It is also called?
Jaundice.
Paleness is not called jaundice. Can you say?
Pallor.
Paleness is also called pallor. And other points?
Pallor, icterus, cyanosis, edema.
Edema. And noting the neck veins, lymph nodes and lymph glands. Sorry, lymph nodes and glands. Neck veins and neck glands. So first is As the subject enters, you may have a general idea about the build and nutrition of the subject, followed by, if you try to maintain that means if you try to do it systematically, this does not have to be an order, plus then should come the vital signs, okay, pulse, respiratory rate, blood pressure and temperature. Next should come pallor, cyanosis, jaundice, clubbing, edema, and neck veins and neck glands. So I told you to remember it as 1451, like this, like the structure of a football team, like this. However you remember, you have to remember in the beginning that we have to note these points. But as we told that when you become professionals, you will note from head to toe. You will not do like this. You will do according to your convenience, make the patient, or better to say the subject, comfortable, make the individual comfortable, take his or her consent, and do it as per convenience of yourself, as well as you have to note the convenience of the subject. That means you don't go like this, that I will check pallor, now you see the eyes, see the tongue, see the hands, and again you remember that you have to see jaundice, again you go to the eyes, again you ask the subject to protrude the tongue. Not like this, that will be irritating for the subject. This is just for the purpose of learning. After you become professionals, what you will do, when you note the eyes, you will note for both pallor and jaundice and anything else you want to note. If there is any complaint in the eye has become red, so you try to notice how much of the eye, whether the whole sclera, which is the whitish part, is looking red, or whether on the or only the conjunctival areas, or whatever you have to note, you note it. You have noted the eyes, now you note the tongue, pallor, tip of the tongue, cyanosis, under surface of tongue, jaundice, the whole tongue you note whether it is pale or not, tongue, hands, when you note the hands, then you note the hands, everything, clubbing, etc., any swelling, anything which appears to you, which even a layman may note that there is a prominent swelling over any part of the body. So these from outside, and proper, what we told in criteria, proper exposure is needed for its physical examination, be it general physical examination, these what we just mentioned just now again, or the systemic examination. So, and we also mentioned that what are the four these key words which we go by in clinical examination, or which we use in clinical examination: inspection, palpation, percussion and auscultation. Inspection is something just by noting without even feeling the subject. That is, as the subject enters, say your outpatients department, or your this what we in common terms called a doctor's chamber or outpatients department, you just note, you can just note the general build and nutrition just by inspection, whether the person is very lean and thin or very obese, whether the face has some scar marks or some swelling, okay, whatever can be noted, obviously, whatever all people are noting, you just try to note whether there is a, or try to think whether there is a medical angle to it, okay. So that can be done just by inspection. Palpation is to feel. Auscultation you have done, like blood pressure measurement requires auscultation. So whatever, temperature, for measuring temperature, a clinical thermometer should be used, okay, or it is better to use a clinical thermometer if not available, with the back of your hands on certain parts of the body. So best is to, for core body temperature, best is to use a clinical thermometer, and that too in the rectal orifice, although commonly we do it under the surface of the tongue in the oral cavity temperature, or the under surface of the axilla, okay. So that requires palpation. All these things requires palpation. Percussion will come to it, auscultation we just told. So this examination of the respiratory system will also include these things, okay, inspection, palpation, percussion and auscultation, and these will contain all four. In general physical examination, only one was not needed, that is percussion. So the word inspection is just observing with the eyes without touching. Inspection means it. Palpation is feel. Percussion, the word means to tap, okay, how we will see. Auscultation is using the stethoscope and listening to sounds, okay. So during blood pressure measurement, which of these you need? Auscultation and palpation. Is it possible only by inspection? No. So, most of these neck veins and neck glands, palpation is required. Okay. Respiratory rate, noting the respiratory rate, what is required? Inspection only. It is inspection only is required, but what we mentioned is that if we just look at the subject for his or her respiratory rate, then the subject may get just a little bit anxious and the respiratory rate may increase. So, we just hold the pulse of the subject as if we are noting the pulse, but actually we are counting the respiratory rate. But that is not palpation. We are not measuring the respiratory rate by palpation or noting the respiratory rate by palpation. We are putting the hand on the pulse just for, this is one kind of fabrication, just fabricating that we are seeing the pulse, but actually we are noting the respiratory rate by inspection. But most things else, temperature requires palpation, so pulse obviously requires palpation. Okay. Heart rate, or if we want to listen to the heartbeats, it requires auscultation. So, in respiratory system, similarly as we told in general physical examination, any clinical examination, respiratory system will also learn under some headings, but when you actually become a medical professional, it will go along with. Maybe you are conversing with the subject, taking some important information from him or her in the form of this history taking, and to save time, simultaneously you are noting things, respiratory system. Maybe when you are listening to sounds over the chest with the help of the stethoscope, obviously neither you should talk, it is better you do not talk, and the subject is also not allowed to talk. The subject has to be instructed, don't talk now, or even don't cough now when we are putting the stethoscope on the chest. Which part of the stethoscope is put on the chest? What is that part of the stethoscope? Do any of you have a stethoscope over here? Diaphragm of the chest piece. So, it is the chest piece, and of the chest piece mostly we use the diaphragm. We use the opposite end, the bell of the stethoscope, usually for low pitch sounds, like classical example is fetal heart sound. Okay. So, this that is when the subject, we use the stethoscope, then the subject should not talk. That means subject, if he or she talks or he or she coughs, then we can't listen to the lung sounds. So, we are coming to that. Inspection, what we know to inspection of the respiratory system. So, before that, whatever we told at the beginning, the criteria for physical examination should be there. So, what are the criteria? So, one is, okay, taking consent, and also it should be a well lighted room, we should take consent, we should make the subject comfortable. One criteria is exposure. So, for the respiratory system, we must expose. Now, anything if you say, again, some of the students are uttering, say, very generalized, that means whatever is obvious, like it is being found in the answer scripts. Even there are definitions of thalassemia, like thalassemia is a disease. Now, this is stupid. Thalassemia is disease. Maybe if someone asks at the age of 6 years, 5-6 years, what is thalassemia? Have you heard? Yes, I have heard. This is a disease. As a student of, say, first standard or second standard or third standard. So, now you have to define thalassemia medically. I have found this type of answer. Thalassemia is a disease. So, this is stupidity at this level. So, likewise, you can't say if we expose the whole body, we can examine the respiratory system as well. If you are to go by only, I'll examine the respiratory system only, then you should expose, you should tell the exposure like that. That exposure would be from neck to the symphysis pubis. Abdomen has to be exposed because respiration, I'll not say respiration, there is a literal difference between respiration and breathing. What is the difference? Respiratory system we have not done now, but you should say this in theoretical. What is respiration and what is the difference of breathing and respiration?
Breathing means inhalation and exhalation. Exhalation means exchange of gas in the
Not only in the alveoli, respiration actually includes everything. It has to be, that means my primary aim, like anemia we defined as less of, that means decrease of RBCs or hemoglobin or both. But what is the aim? So that tissue hypoxia does not occur, because the role of hemoglobin and RBC is to carry oxygen. So here also aim exchange of gases, not only, it will not suffice only of exchange of gases in the lungs. So, exchange of gases has to be at the tissue level also. So, that all is included in respiration if we speak very strictly. But breathing means only the process of taking in air inside the lungs, and that means the taking out the air from the lungs to the outside. So, this breathing pattern, to note this breathing pattern, whether the breathing is going on, we need to note the abdomen also, the belly, whatever in layman's terms it will be the belly. So, both the thorax, both the chest and the abdomen, both the thorax, both the chest and the belly region, both the thorax and the abdomen have to be uncovered. So, exposure is from the nape of the neck hole to the symphysis pubis. That means the upper part of the clothing have to be removed, and side by side comes the obvious, which is the obvious. So, if you have to expose, if you are a male clinician, then for a female subject there has to be a female attendant. If you are a female clinician, for the male subject there has to be a male attendant. So, whenever we expose. So, what do we note in inspection? One point we already know, respiratory rate. But before that, just after exposure, what we note is the shape and size of the chest. So, we will find different terms like in the books, like barrel shaped chest and all, pigeon shaped chest, barrel shaped chest, and these are found in different diseases or conditions. So, actual what is the normal shape? In the first year of medical school, we try to learn what is normal, so that we can compare with abnormalities when as medical students you see actual patients. So, the shape of the chest, at least whatever you know, whatever you say or not, say that I am noting the symmetry. If one half of the chest does not match the other in this shape and size, then it is asymmetry. So, during inspection it may be noted if there is gross asymmetry, or what we note, the position of the trachea is grossly deviated. This position of the trachea can be noted just by inspection, and it can be made out whether it is very large deviation, we may say, very much to the right or much to the left, then it can be noted by inspection only. But it has to be confirmed by palpation, that whatever you are noting this prominence over this throat region, you put two fingers on the two sides of it. So, this becomes palpation, 2 fingers. Now, how many fingers you can put? First put only one finger. Then if on one side more fingers are going, on another side less, then the trachea is deviated to the side where less number of fingers we can introduce. Okay, obviously not more than 2 or 3. So, all 5 fingers, there is not so much space, but that is to be confirmed by palpation. Likewise, symmetry of the chest, if there is gross asymmetry, the chest, the whole of this is called the mediastinum. As you have thorax been discussed in the anatomy, so you know the term mediastinum. So, this is called mediastinal shift. If the mediastinal is again shifted, there is a large shift, it can be made out by inspection and obviously confirmed by palpation. Now, what we do is stand on so we ask the subject, it is written in some book, someone just read out 45 degrees and all, but this is just one, you may say, clue or just one statement. So, sometimes we have to modify, sometimes not, we have to modify according to the part of the examination we are doing. So, we will go to the back of the subject, or we may stand in front and we will just put 2 fingers, okay, where these 2 thumbs on the 2 sides, and hold the subject from the side with the rest of 4 fingers like this. Okay, say over the belly and 2 fingers, and ask the subject to breathe in and breathe out. So, we will not remove our thumbs as clinician by ourselves, but if there is asymmetry, one thumb will be seen deviating more than the other. That is passive movement of the thumb after we have put the thumb, 2 thumbs by the side. So, we will do it when we go to that room, we have to do it ourselves, you have to do it yourselves. So, that will check whether there is asymmetry. If there is very little, then maybe it is just noted on palpation, but if there is very gross asymmetry, then what will happen? It can be seen in inspection and it can be noted in palpation. Even before that, shape of the chest, before going to palpation, whenever we are just when at that point, whenever we have not even felt the subject in inspection, any again any swelling, any scar mark, if there is any scar mark after exposure, you ask what has this scar mark come from, was there a previous any history of surgical intervention and all. So you see, whenever we are becoming, as we become more experienced and when you become a medical professional, history taking and clinical examination will go side by side. So you expose the upper part of the body, you are maybe examining there for the respiratory system, for the lung sounds and all, and you note a scar and you go on asking what is this scar for. So that is again a part of history taking. So we are studying this topic by topic, points by points, just for the sake of learning. When you become medical professionals, you do it all together according to your convenience and noting that the subject is comfortable with the examination. So this is inspection. These points to note, few points to note. They are given by points. The shape and size of the chest, any obvious swelling, scar mark. Okay. Then respiratory rate, whatever. Again by inspection, we note the respiratory rate. So these things. By palpation, we just confirm these inspectory findings like position of the trachea. Inspection also, another point is position of the trachea. If in the first year of medical school, some old school examiners may ask like this, tell me the points. Usually it is not asked like this. Usually we, when evaluating the students are required to perform themselves. This is what is clinical examination is all about. You are required to perform by yourself. But sometimes, I will not say only old school examiners, when they are, we use the word failing miserably. So we are seeing in Viva and during examination that they are being not able to perform anything, then at least say the points, what are the points. So what should we see in inspection? Then you have to utter these one by one. That shape and size of the chest with symmetry, shape, size and symmetry of the chest, position of the trachea, respiratory rate, these things, any obvious swelling, scar mark, these things. In palpation, we confirm the inspectory findings, position of the trachea, shape and size of the chest, and also in palpation, what we do, we keep our ulnar border of the hand on the in the intercostal spaces. So again, to note the intercostal spaces, we should learn something. So as you have done the superior extremity of thorax, so you know about the clavicle. So just below the clavicle, if you go, it is the intercostal space is the space between the ribs. So just behind the clavicle is the second rib. Have you seen X-rays in anatomy till now?
Yes.
X-rays, X-ray of the chest in anatomy. So you must have noted. So you must have learned that behind the clavicle, the first rib, actually the first rib goes behind the clavicle and the second rib is just below. Obviously, the ribs are named according to up, above downwards, 1, 2, 3, 4, 5, 6. Intercostal spaces are between the ribs. So we keep our hand on the intercostal, in the which hand means the ulnar border of the hand, and medically hand is which part? Distal to the wrist joint. Not in layman's terms, hand is not the whole upper limb. So arm, forearm and wrist, arm, forearm and hand and parts of the actual means part of the upper limb, which we call the hand. Very in layman's terms, the whole upper limb is called as the hand. So actually the parts of the upper limb band, arm, forearm and hand. This ulnar border of the hand, ulnar border means medial border, okay, ulnar border or medial border, the same thing. So we put it on the intercostal spaces. Two hands we can put together and ask the subject to speak out a monosyllable, like subject is asked to pick out like this, 3, 3, 3 or teen, 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 like this, 99, 99, 99 or 1, 1, 1, like this, thrice, one, just repeating it thrice, 1, 1, 1, loudly. And what you try to note, and this is called, you note these vibrations. So this is called vocal fremitus. This is called vocal fremitus. So this we are to note. So we are not using any other instrument, not the stethoscope, just putting our hand on the ulnar border of the hand on the intercostal spaces, and you have to do it on the intercostal spaces one after another. After the second, first intercostal, then the second, then the third, then the fourth, like this, all the intercostal spaces we are to cover. Now, the rule is that whenever you may start from the left or right, that does not matter, but the rule is that whenever you do left of one side, you have to do right of that side also. That means that level also, not right, left of one side does not mean anything. Left of one level, that means first or second, then whatever, third, fourth, whatever. So, fourth of that side also. So, we do like this, left, right, like this, but when we put the hand, then what we can do it simultaneously. Okay, you have to do both sides together and compare your results. Anywhere you find any abnormality, okay, vibrations are we are feeling the vibrations are coming on the left side, but not as on the right side. We should note that, because this is for vocal fremitus. These things are coming if the lung is not, I can say normal. If it is somewhere, it has say air is not going into the lungs, then these our findings will change. So, similar vibrations can't be found. So, that is to be noted during palpation, and this when done with the help of a stethoscope, same thing, asking the subject to speak out like that, and done with the help of the stethoscope, the name of the same thing becomes vocal resonance. When we are hearing it, becomes vocal resonance. Now, you see, we just mentioned we should do it on both sides. So, as we can do it on both sides with our both hands, we can do it together both sides. Say the third intercostal space, both sides together, third of the left, third of the right, fourth of the left, fourth of the right. But when we are pushing the stethoscope, we are using only one stethoscope. So, as soon as we do on the left side, we have to do on the right side. But during stethoscope, what we do not go by the intercostal spaces. It is not possible to put the stethoscope right like that following the intercostal spaces. So, there are some areas. So, what are the areas to use the stethoscope to hear sounds on the front of the chest as well as the back? So, one is apex beat is something else. Apex beat we see with the stethoscope, it will be discussed I think on Monday during the cardiovascular system. So, apex beat, yes, apex beat can be noted along if we say it like this, inspection of the chest. So, see, again I am repeating, when we are becoming medical professionals, we are not doing like this. Okay, now I will do the respiratory system, now we will hear the lung sounds, then I will go for the whatever he mentioned apex beat. If all of you know about this term, I don't know whether you know, so he knows, he just mentioned. So, apex beat, we can see it together, we will see it together. So, examination of respiratory CVS probably will go along simultaneously, but now we are learning the respiratory system, we just stick to it. So, respiratory system, we are putting the stethoscope. What are the areas? Supraclavicular, infraclavicular, inframammary, okay, inframammary, and on the back suprascapular, infrascapular. So, on both sides, again whenever we are putting the stethoscope also, if we cite the right suprascapular area, we will also see just after that the left suprascapular area. And another is interscapular area, nothing to write down, everything is in the whatever books you read, these are there, the areas. So, again you see these are just for the sake of, just means at least more for the sake of learning. When you become medical professionals, as you go on, as it comes to your, in your practice, your brain can automatically adjust these things, or that you will never miss. As you go on practicing, you will never miss that we put suprascapular, infrascapular, and the interscapular cannot be both sides, it is between the two scapulae. So, it is just in the middle, interscapular, but otherwise all others on both sides. Okay. So, we note not only vocal resonance, what we note when we are talking of vocal fremitus or resonance, we are asking the subject to speak out, but when we are noting for lung sounds, that means breath sounds, with auscultation, breath sounds, then we put the stethoscope and we will have to ask the subject, don't cough or talk now. Even if the subject's primary complaint, maybe he or she is having very vigorous coughing for 3 days. But when you note, you ask, try to control yourself, don't cough at this time, I am trying to listen to your breath sounds. So, most of the times it is not very relevant to not required to speak out what I am seeing. Okay, I will check for your pallor, I will check for your cyanosis. The layman does not understand these terms. Okay, but whenever you go to note the breath sounds, maybe the subject, যে আপনার, if you say in Bengali, আপনার শ্বাসের শব্দ আমি শোনার চেষ্টা করছি, আপনি এখন কাশবেন না, তাহলে আমি শব্দটা শুনতে পাবো না. This will be relevant to him. He or she will understand, him or her, he or she will understand what you are trying to do, your purpose, then maybe he or she will be cooperating with you more. Okay, most of the times it is not required what you are seeing, because he or she won't understand cyanosis. So you just ask him or her to protrude out the tongue. I'll see a few things. But breath sounds, when you examine breath sounds, it is better to say, because just this is just common sense, that maybe the subject will cooperate with you more. Achha, Doctor, the doctor is trying to listen to my sounds, my breath sounds, so I will cooperate by not coughing or not talking. So this comes by proper communication. This ATCOM has been introduced in the syllabus just since 2018. When we entered the medical course, this was not there, because it has been seen sometimes due to lack of proper communication. That is behavior of the professional, everything it includes, but proper communication in medical terms also. In which part of the physical examination, how you have to communicate. This is also a part of your learning and your performance as a medical professional. So this is, you put the stethoscope. So instead, with the help of the stethoscope, we listen to the sounds as well as the vocal resonance, and obviously the breath sounds. And not only those areas, other areas are infraaxillary, okay, on the both sides of the chest, lateral walls of the chest, and that is in the infraaxillary area. And remember, maybe the best area to auscultate these lung sounds are those areas, because no organ is interfering with the lung sounds. Over the chest, there may be the heart just towards the lower part of the chest, cardiac end of the stomach, and all this may towards the lower part of the chest, the liver. If the liver is enlarged, sometimes there are chances that there will be organ overlapping, but on the sides, usually, unless there is any abnormal growth of something, very abnormal growth, nothing is overlapping. So the best areas to auscultate for these breath sounds are the two sides, lateral. And what type of breath sounds? Breath sounds, it will be again discussed in the theoretical classes, that what are vesicular breath sounds and what are bronchial breath sounds. Those are for inside the normal lungs are vesicular breath sounds. Bronchial breath sounds are over the large airways. Okay, mainly we are talking of the bronchus, so the trachea and the large bronchi. So if you put the stethoscope over the trachea, this you can do, this you can get an idea what is the difference between bronchial, what are the difference in character of the bronchial and vesicular breath sounds, how they are, by listening, how can you differentiate? You can put over your own trachea and your own these areas over your own lung. So that will differ. Over the trachea and the large bronchi, these are called bronchial breath sounds, and over the normal lung, in the lung alveoli, whatever the character of the sounds produced, these are called vesicular breath sounds. So this is about inspection, palpation and auscultation, more or less about of the respiratory system. About percussion is tap. Percussion is to tap. So what we do is again we have to know how to calculate or how to locate the intercostal spaces. We put the middle finger of our, in the books it is written, put the middle finger of your left hand on the intercostal space and tap the middle finger with the right hand, with the middle finger of the right hand, or one finger of the right hand over that finger. Okay, I'll say that don't say like that left hand and right hand. It is because mostly the right hand is the dominant hand. Put the middle finger of your non-dominant hand. If you are a left-hander, then you put the right hand, finger of the right hand of the intercostal space and do it with the left hand. So again, this is to be done on both sides, 1, 2, and as we have, that means the one intercostal space, so say the second of one side, second of right side, again third of left side, third on right side, and you have to continue like this. and feel whatever, in at least I teach it like this, feel whatever you get a finding, you note that. In the first year of your medical school, again I have told this many times before, if examiners are also not concerned much about what you are finding, if it is not a very gross wrong finding, say the pulse rate is 80 per minute but you say it to be 30 per minute, that is a grossly wrong finding. But mostly we are concerned whether we are doing the procedure correctly, because findings will mostly be normal. We are doing on our own colleagues, own fellow mates, the findings will mostly be normal, or there may be somebody from some staff who is volunteering, some institutional staff who is volunteering for your exam, but they are mostly healthy. My point is mostly healthy people, so you will not get very grossly abnormal findings, but whether you are doing the procedure correctly, that is what we are seeing in the first year of medical school. Okay, so I think these are more or less the points to note, and some specific findings or specific causes of this, what barrel shaped chest, PGN shaped chest, like PGN shaped, we also say pesus, I think the term is excavatum. So this is found in rickets, okay, a disease called rickets in children. Okay, so these things are written along with in the books, and some you will find some terms like woody feeling, stony feeling, like the lungs are solidified, these terms. But I think these are more relevant once you have learned the procedure, at least the procedure, how to do it. This becomes what findings you are getting. That is the same thing. That findings we are more concerned with, you will be more concerned with when you see the actual patients. Probably in MBBS, when you will be appearing for your medicine, when you learn medicine, that is, when you are appearing for your medicine examination, the examiners will be more concerned with the findings. For now, you first learn the procedure. Obviously, after going today, read the book, again practice it. But for today, whatever, I think 1 hour is left, yes, almost 1 hour is left, we practice we do these procedures, we try to do it. Okay, again, ideally proper exposure is needed. So you are doing on your own fellow mate, so আর পরপর করো, ইন্সপেকশনে যদি প্রপার এক্সপোজার না থাকে তাহলে তো একদম না থাকলে তো যেগুলো মানে কি কি দেখতে হয়, আবার সোয়েলিং, স্কার মার্ক, এগুলো অবভিয়াস। হ্যাঁ, শো কমফোর্টেবলি শো, কোনো লজ্জার কিছু নেই, লজ্জা পেয়ে শেখা যাবে না। হ্যাঁ, এটা যদি করতে হয় তাহলে তোমাকে বেটার হচ্ছে বসিয়ে এইভাবে হাতটা রেখে এইভাবে করো, বসিয়ে করো। এবার এটা অ্যাকচুয়ালি প্রপার এক্সপোজার ছাড়া বোঝানো খুব মুশকিল, যে মানে তুমি দেখতে পাচ্ছ না সিমেট্রিটা ক্লোদিংস এর উপর দিয়ে, তুমি ওই সিমেট্রি বোঝার জন্য অ্যাটলিস্ট প্রসিডিওরটা করো। মোর ইম্পর্টেন্ট দেন ইট ইজ, মানে ফ্রম দ্য ক্লিনিক্যাল পয়েন্ট অফ ভিউ, ভোকাল রেজিস্ট্যান্স, ভোকাল প্রেজেন্স, মোস্ট ইম্পর্টেন্ট ইন clinically আমরা যেগুলো করি অ্যাকচুয়ালি আফটার বিকামিং মেডিকেল প্রফেশনালস, মোস্ট ইম্পর্টেন্ট ইজ মেবি ইন রেসপিরেটরি সিস্টেম ইজ দ্য ব্রেথ সাউন্ডস। অবভিয়াসলি অন্যগুলো ইম্পর্টেন্ট কিছু কিছু জিনিস পিক আপ করার সময়, কিন্তু দিস আর বেসিক্স, কিন্তু বেসিক্যালি মোস্ট ইম্পর্টেন্ট ইজ ব্রেথ সাউন্ডস। ঠিক আছে
স্যার, যখন আমরা সিমেট্রিটা দেখছি,
হাত ওখানে রেখে
করবে, যখন শ্বাস নিচে যেদিকে আঙুল উঠে যাবে ওই দিকে কি অ্যাসিমেট্রি, এরকম কিছু আছে না?
অ্যাসিমেট্রি যদি হয় তাহলে একদিকে যদি চেস্ট বেশি সরে গিয়ে থাকে তাহলে আঙুল সেদিকে বেশি সরে যাবে, এটা কমন সেন্স। দাঁড়িয়ে রেসপিরেটরি সিস্টেম হবে না, হয় কিছু বসে কিছু শুয়ে। প্যালপিটেশন নয়, প্যালপেশন। ইয়েস, হ্যাঁ, দুদিকে দুটো ফিঙ্গার্স। পড়ো কি লেখা আছে, কিভাবে করতে বলছে পড়ো, পড়ে পড়ে করো, কিন্তু আরো বই তো আছে, সেই জন্যই তো বই রাখা। গ্রুপ হও, পড়ো, অসুবিধে জিজ্ঞেস করো। এই এক জায়গায় 5-6 জন করে কোনোদিন শিখতে পারবে না। হস্টেলেও যখন করবে, যত কম গ্রুপে করবে তত ভালো। একটু রোগাকে একটা স্টেথো দাও। সো যখন শিখে যাবে মেডিকেল যখন হয়ে যাবে তখন এরকম বসো বসো ওইদিকে ঘুরেই বসো। So instructions have also to be clear. জোরে শ্বাস নিন। জোরে শ্বাস নিতে থাকুন, যতক্ষণ না আমি বলবো জোরে শ্বাস নিতে থাকুন। গভীর শ্বাস নিন, গভীর শ্বাস ছাড়তে থাকুন। ওকে, ডিড ইউ ফলো অ্যান্ড ডিড ইউ অলসো ফিল? আমরা কি করলাম? স্পাইনাটাস নয়, সুপ্রাস্ক্যাপুলার। হ্যাঁ করলাম, তাহলে কি করলাম? রাইট লেফট, আবার এটা লেফট রাইট, মানে একটা লেভেলে করলে দুটোই দিকই করতে হবে। আর ইন্টারস্ক্যাপুলার ক্যানট বি বোথ সাইডস, সেরকম সামনে করো। সুপ্রাক্লাভিকুলার, ইনফ্রাক্লাভিকুলার, ইনফ্রাম্যামারি। আর যখন ইনফ্রা অ্যাক্সিলারি করবে এই হাত তুলে। রেসপিরেটরি সিস্টেম বিগিনারদের আমরা বলি এইরকম হাত তুলেই করতে বলো, যে হাতটা তুলে এরকম মাথার উপরে। এই ইনস্ট্রাকশনগুলো প্রপার হবে যে আপনি হাতটা তুলে মাথার পেছনে রাখুন, আর আমি আপনার স্টেথো দিয়ে আপনার বুকটা শুনবো। ততক্ষণ আপনি গভীরভাবে শ্বাস নেবেন এবং শ্বাস ছাড়বেন, মাঝখানে কথা বলবেন না বা কাশবেন না। ফার্স্ট ইয়ারে কিন্তু যখন এক্সামিনার প্রসিডিওর দেখবে তখন এক্সামিনার শুনছে যে তুমি সেই ইনস্ট্রাকশনগুলো দিচ্ছ, সেটাই তোমার পরীক্ষা ফার্স্ট ইয়ারের পরীক্ষায়, যে তুমি এগুলো বলছো কিনা। এগুলো না বলে হয়তো যেহেতু তোমার বন্ধুই, সেও জানে, সে হয়তো নিজে থেকেই হাত এরকম করে ফেলবে, কিন্তু এক্সামিনার নোট করবে যে তুমি তাকে বলোনি। রাইট? ইনফ্রাক্সিলারি করতে হলে তখন তো হাত তুলতে বলতেই হবে, তাই প্রথম থেকেই তুলতে বলবে। ঠিক আছে? তখন তুলতেই হবে, কোনো মানে নেই, কিন্তু যদি মনে রেখে রেখে করতে পারো তাহলে ঠিক আছে। আর যদি না যদি মাঝখানে হবার ভুলে গেলে, তার থেকে আগে থেকেই তুলতে বলে থাকা ভালো, যে আপনি হাত এখানে করুন, আমি আপনার বুকটা দেখে নিই, স্টেথো দিয়ে বুকের শব্দ শুনবো। এটাই তো বলতে হয়। এটা যখন একটা মানে একজন লেম্যানের কাছে যখন বলবে, এভাবেই তো তাকে বোঝাবে, তো সেইভাবেই করবে। তো তো কি বাংলা বোঝে? হি ডাজ নট আন্ডারস্ট্যান্ড বেঙ্গল। তো তুই বসো, ওইটুকু বুঝতে হবে এখন আর কি, মানে এই জোরে শ্বাস নিন এইগুলো এখন বুঝতে হবে আস্তে আস্তে। আচ্ছা, চুলটা একটু, এটাও কিন্তু পার্ট, এই যে একটু চুলটা সরিয়ে দেবেন, আমি দেখবো, স্টেথো বসাবো, হ্যাঁ এইগুলোও কিন্তু পার্ট অফ দ্য কমিউনিকেশন। আচ্ছা, আমি এইটা বলে দিই, এইটা হচ্ছে কমিউনিকেশন। আমি যখন আপনাকে বলবো তখন আমি যেটা বলতে বলবো আপনি সেটা বলবেন, আমার সাথে সাথে বলবেন। জোরে জোরে, জোরে জোরে বলুন, 3 3 3। আরেকটু জোরে। সো দিস ইজ আওয়ার কমন, যে সাবজেক্টকে যদি এটা কি হচ্ছে, দিস ইজ হি ইজ গেটিং অ্যাকাস্টমড। তারপরে আর আমি আর বলছি না, আপনি বলুন, স্টেথো বসালেই সে বুঝে যাচ্ছে যে আমাকে এটাই করতে বলা হচ্ছিল। সো সি ইজ গেটিং অ্যাকাস্টমড লাইক দ্যাট। এখন এরকম মানে এখানে শিখছো, নিজেদের সামনে হাসি পাচ্ছে, হাসি পেলে হবে না। ইউ হ্যাভ টু লার্ন প্রপারলি, যেভাবে করবে সে এই সেকেন্ড ইয়ার থেকে যেভাবে গিয়ে ওয়ার্ডে করতে হবে সেইটাই এখানে করবে। ওখানে কিন্তু আর কেউ শেখাবে না, ইন দ্য সেন্স যে শেখানোর কথা হলেও ধরে নেবে যে তুমি ফার্স্ট ইয়ারই এগুলো শিখে এসছো। যদি কেউ না পারে তাকে অবশ্যই দেখিয়ে দেওয়ার কথা, কিন্তু ধরে নেবে এগুলো ফার্স্ট ইয়ারের। ওখানে তো আরো জিনিস শেখাতে হবে না তাদেরকে। ওই ওয়ার্ডে পড়াতে পড়াতেই মেডিসিন টিচার তোমাকে শেখাবেন যে এইটার তাহলে এখানে এইটা হলে এটার কি ফাইন্ডিংস হতে পারে, এটার কি ট্রিটমেন্ট হতে পারে। তো তখন যদি এইটা আবার পুরোটা শেখাতে হয়, সেটা তো সম্ভব নয়।
দেখার পর আমরা মানে ভাইব্রেশনটা দেখব।
মানে এটা আমরা কি স্টেথো দিয়ে যখন করলাম সেটাকে ভাইব্রেশন তো বলবে না, টার্মটা বলবে, এটা ভোকাল রেজোনেন্স। একই জিনিস আমরা যদি হাত রেখে করি সেটা ভোকাল ফ্রেমিটাস, সেটা হচ্ছে বাই প্যালপেশন। লোকেট দ্য ইন্টারকস্টাল স্পেসেস, আলনার বর্ডার অফ হ্যান্ড যে ইন্টারকস্টাল স্পেসেস ওপর থাকবে সেইটাকে দেখতে হবে, সেটাও করতে হবে। এটা কোন সাইড, ওদিকে মাথা দিতে বলো, না হলে এদিকে আসতে হবে। ডু ফ্রম দ্য রাইট সাইড। ওইরকম ভাবে রেসপিরেটরি রেট দেখে না, রেসপিরেটরি রেট মানে সাবজেক্টকে বুঝিয়ে দিলে হবে না যে রেসপিরেটরি রেট দেখছে। ওকে বলেছি আবার কি, ও তো সব জানি, মানে ব্যাপারটা হচ্ছে যে যেকে পালস মাপছি বলছি, জাস্ট পালসে হাত রেখে তুমি ওদিকে তাকাবে। রেসপিরেটরি রেট দেখার অ্যাকচুয়াল নিয়ম হচ্ছে সামনে এসে হ্যাঁ সুপাইন করে তার ফুট এন্ড থেকে দেখা, কিন্তু ওইটা করতে গেলেও খালি প্রথমে পারবে না, তাহলে সাবজেক্ট বুঝে যাবে। Yes, this is the procedure, but here you will get normal findings. That means the movement of the thumbs will be equal on both sides. You locate the intercostal space first. Behind the clavicle is the which rib? তোমাদের বেশি হ্যাঁ তাহলে তার নিচে, তাহলে intercostal space is just below the upper rib, the same number. ক্ল্যাভিকেলের পেছনে হচ্ছে ফার্স্ট রিব, ওটা ভেতর এখান থেকে পারবে না, তার মানে ওটা ঠিক নিচেই যে স্পেসটা পাচ্ছ তারপরে আরেকটা রিব পাচ্ছ, তাহলে সেকেন্ড রিবটা যদি পাও তাহলে তার উপরেরটা হচ্ছে ফার্স্ট স্পেস, তার নিচেরটা সেকেন্ড স্পেস, তারপরেরটা থেকে তো পাবেই। The hand will be, if you have located the intercostal space, better to locate by fully exposing, then you keep the hand like this and yes. What I forgot to tell is when during percussion, percussion টা করতে হবে শুইয়ে, percussion you will hit with the middle finger of the dominant hand, that means so not hit, the word is tap, tap with the middle finger. This movement will come from the wrist joint, not with the elbow joint, elbow will be fixed in air. This is one important point. এই রকম নয়, elbow will not move, the movement will come from the wrist joint. Okay, everybody see, during percussion you are keeping a hand on the intercostal space, that is middle finger of the non-dominant hand, okay, and with the finger of the dominant hand you are tapping and the movement is coming from the wrist joint, the elbow will not move. That is one important point.